Hopefully, this will be easier for me to get uploaded onto the internet. I don't have the most reliable internet sometimes, so hopefully, this will make the upload a lot faster. I always want to start by acknowledging the fact that you guys have covered a lot of information. Um, it feels like you've covered a lot. That's because you have covered a lot. Remember that everything that you have covered is fair game. Be sure that you take the time to review the supplemental learnings that I provide for you with each module. That information is very important. It will help hopefully guide your study process and help highlight things that are important and also explain some learning gaps or areas that I find students struggle with. Make sure you take the time to review course discussion and any feedback that I may have provided. Typically, what I do is make sure if something's extremely important, I make sure that that is included in the course announcements. Additional study tips. Please make sure you have the ability to understand the epidemiology of conditions, recognize typical symptoms of the condition, identify predisposing factors for an illness, know how to manage an illness, and this includes medication management, know when a referral is needed. It's important to understand what is in your wheelhouse and when it is time to move on to a specialist. And that's when the referral will come in. So you need to know when that should happen. And always be ready to provide patients with instructions because in real life, patients have a lot of questions. So you should be educated on what it is that you are discussing with the patient and be prepared for their questions and make sure you have some solid answers. We'll begin with a review of mental health. The first thing I'll talk about is anxiety disorder. Anxiety disorders are the most common mental health condition. Specific phobias lead to anxiety disorders. The most common types of anxiety disorders are specific phobias. So that would be some people have a fear of white t shirts, is what I'll use. That could be a specific phobia to a person. There is general anxiety disorder, panic disorders, obsessive compulsive disorder, and post traumatic stress disorder. We'll look at general anxiety disorder. This is a condition of excessive worry and anxiety. In order to meet the criteria for this diagnosis, you must have at least three of the following: one, easily fatigued, restless, or having a feeling of being on edge, difficulty concentrating, irritability, muscle tension, and sleep disturbance. Again, you have to have at least three of those before you are diagnosed with the general anxiety disorder. Panic disorders are recurrent and these are unexpected. They are very abrupt, and there will be a surge of intense fear or discomfort that will peak within several minutes. So, a panic attack doesn't last for several hours. If a patient has a condition that is going on for hours or days, we want to think beyond a panic disorder and consider other possible diagnoses. Symptoms of a panic attack are palpitations, sweating, trembling, feeling of choking, chills, or hot flashes, GI distress, so think of nausea and vomiting, feeling dizzy, fear of losing control, fear of dying, numbness, or a tingling sensation. If you look at these symptoms can also be indicative of more complex causes or other causes besides panic. I don't want anyone to make the mistake of chalking something off to a panic disorder when there could be a more acute or serious illness that is actually at bay, for instance, a heart attack. So you don't want to always rule things to be a panic attack when there are other etiologies that you do need to rule out. So make sure you have really strong differentials when it comes to a diagnosis of a panic attack in your setting. The medical management of anxiety disorders is included here. I have basically copied a chart that is listed in your book. What I want to bring your attention to is Medicines such as benzodiazepines, patients sometimes will prefer these because of their rapid onset. The problem with that is there is a risk of dependence with these medications. People become sluggish while they're taking these medicines, and there's also a fall risk with the elderly. I'd also like to bring your attention to the SSRIs and the SNRIs. If you look at the different things that it treats, you'll see that it covers everything, where benzos don't have that same coverage. The other advantage of the SSRIs or the SNRIs is that they are also effective for depression, and anxiety and depression do coexist. The side effects or the downsides to that is there's a slow onset, so patients don't take them and instantly feel better. It takes a little bit of time. And there are also side effects sometimes that patients do not like, for instance, weight gain. So some patients will stop the medicine because of the weight gain that is associated with those medicines. When looking at depression, you have to have at least 5 of these within a 2-week period. And the key word here is and, at least one symptom before. One symptom must be diminished interest or pleasure or a depressed mood. So let me say that again. So you have to have some of these symptoms listed below within a 2-week period, plus you have to have a diminished interest or pleasure in things that you normally would find pleasurable, or a depressed mood. So the symptoms are depressed mood, diminished interest, significant weight or appetite change, a sleep disturbance, psychomotor agitation or retardation. So these people are not behaving like themselves. Things that normally would make them happy no longer make them happy, or they have lost interest in things that they have a sincere interest in. There may be weight changes. People may eat too much or eat too little. So those are usually the things that people will start to notice. The big thing is when you're dealing with adolescents and children, that depressed mood may actually present as irritability. So make sure if you have an irritable child or an adolescent, think depression. I have included a screening questionnaire. So take a few moments to review that. There are risk factors for depression. They are prior depressive episodes, stressful life events, substance abuse, family history, poor social support, dementia or recent childbirth, female gender, or serious medical illness. The treatment of depression is best handled when medication and psychotherapy are included in the plan. So sometimes people want to do just the medicine, but you need to make lifestyle adjustments. You need to have coping mechanisms in place. You need to sometimes deal with root causes of old traumas that can lead to depression later on. When prescribing a medication for a patient, be sure to start low. The reason for this is because you want to decrease the side effects. So you'll use the lowest effective dose on a patient. Most patients will see an improvement within 2 weeks, but please allow 6 to 12 weeks. If a patient doesn't show any improvement after 4 weeks, then you should consider an adjustment in your medication. I have included a table of medication options. Please take a few moments to review that table. Next, we'll look at neuro. Dizziness and vertigo. Really, this one is kind of self-explanatory. So the symptoms of vertigo is you will feel dizzy, you will feel unbalanced, and I want you to have an understanding of what could potentially be causing the vertigo. So this is one of those instances where I want you to go back to your book. I've also included a video on a future slide that really does a good review of vertigo. I want you to know what the symptoms are and when to refer in instances of vertigo. Patients may complain of being lightheaded or feeling as if they are going to faint. It is very uncommon for a patient to have episodes of hypoglycemia and seizure-like activity with vertigo. It's also rarely a manifestation of an impending stroke, but as an astute clinician, I don't want you to miss a stroke. So make sure you always have those types of things on your differential list. When people are off balance, they may have some difficulty seeing, standing, keeping up with where all parts of their body are. But as a clinician, it is your responsibility to do a complete medical examination to see if there's any underlying medical causes that you could be overlooking. So here we are back to the H&P. I have a video here on the Hall-Pike Dix maneuver. I can pretty much guarantee you'll see this on your boards. If I were a betting woman, I would bet on seeing something about that. So make sure that you know what the Hall-Pike Dix maneuver is and what it is used to help diagnose. You want to refer when there are neurological signs, if you have a suspicion of an underlying cardiac disorder, if the diagnosis of vertigo remains unclear, or if there's a lack of response to standard treatments. And remember, when you are treating these patients, you want to find the underlying cause and you want to manage the symptoms for the patient. So here is the video that I have included. I think it's an excellent video. So take a few moments, pull up the PowerPoint, and actually review this video. It'll take probably about 10 minutes, I believe. Another thing that you will probably see on at least your board examinations will be trigeminal neuralgia. The diagnosis of trigeminal neuralgia is typically based on clinical findings. The patient will describe pain along the trigeminal nerve, and I have included images of the affected areas on your PowerPoint. I also included this in your course announcements. Pain is very specific. Patients will typically describe this as sharp or stabbing, and it's usually going to be unilateral, so not on both sides of the face. You rarely need advanced imaging. When you get into advanced imaging, it's because you are trying to rule out another underlying cause or etiology. Same thing for testing. When these things step in, when you start drawing labs and you are doing the advanced imaging, it's because you're looking for something else. The treatment for it, first line, is anticonvulsants. When you start the patients on these medicines, again, you start with the lowest effective dose. We want to provide pain relief with as few side effects as possible. A second line, which means you can add medicines or you can switch. Baclofen would be an example, and I have others listed here as well. Do not abruptly withdraw the medication and refer to neurology. When you find you give the patients these medications and they are not working, or sometimes you can send a patient to neurology just for a consult to make sure that you are on the right path with this patient. Let's take a few moments to look at headaches. I've included this slide, and I believe I've also included this in your course announcements. These are 3 common types of headaches. Excuse me. Please be sure that you are able to differentiate the different types of headaches. The first headache we'll look at here is, let's look at the tension headache here first. The onset of that will be slow. It's usually going to hurt on both sides of the head. The treatment for that is over-the-counter pain relievers. Sometimes lifestyle adjustments will help with this patient, and sometimes just lifestyle is all the patient will need. Exercise and stress relief are the big lifestyle factors that can make a difference for these types of headaches. Another headache is a migraine. Migraines, patients will experience throbbing pain, nausea or vomiting, or both, light sensitivity. This can last for several hours to several days. Rescue medications are used to stop a migraine, and there are also preventative medications that can be used for migraine management. The next type of headache is a cluster headache. You'll see this more in men than women. Pain is typically on one side. They'll get red, watery eyes. One of the things that this type of headache responds well to is oxygen. So if you see this on your board test, your board examination, the answer is going to be oxygen management. That is what's going to set this apart from the other headaches, that and the fact that it typically happens with men. With headaches, there are certain red flags that you should always be aware of, and be sure that you review these and document them. Red flags, which means we need to look beyond the obvious diagnosis and we need to do some additional digging to make sure there are not other underlying etiologies that could potentially be fatal if these are missed. A headache after the age of 50. So if you have a patient that comes in that doesn't get headaches and suddenly they come in with a headache and they're 53 years old, that is a red flag. You need to do some bigger, wait, I can't say this. You need to dig deeper. The next is a thunderclap headache. Patients that suddenly they hear clap, the headache is like that severe. Those patients need to go to the emergency room immediately. Other red flags are neurological symptoms, vision changes, mental status changes, neurological deficits, emergency room immediately. If they are having halos around lights, if a patient has immunosuppression or cancer and they have a headache, you want to make sure that you do some additional evaluation of that patient. Make sure you're not missing signs of meningitis. Make sure you're not missing giant cell arteritis. And I've included some hyperlinks. Make sure you take a few moments to review the hyperlinks that are also included. The management of migraines. The big things that you will see over and over and over are: one, you need to eliminate the triggers. So for some patients, food is their trigger. The one that people have trouble with sometimes could be cheese or wines. Make sure the patients know what their lifestyle triggers are. Look for behavioral changes. Again, this is a lifestyle trigger. If some people don't get enough sleep, they suffer a migraine. The next thing is abortive therapy. That means, what do patients do to make a headache stop? Patients are able to use NSAIDs. Some people find Tylenol alone is enough to relieve the pain. NSAIDs and Tylenol can be combined for pain relief for some patients. For more severe headaches, we look at other medications such as triptans. When you're managing a patient with migraines, make sure that you also treat other symptoms such as nausea and vomiting. So make sure you give these patients antiemetics. And be sure to complete a complete H&P on every migraine. Look for those red flags and know when it's time to refer on to a specialist, to oncology, to the emergency room. When you see those red flags, the big thing is you need to refer. And that concludes